So welcome to Wemcast with me, Eoin Walker, the World Extreme Medicine Trauma Lead. Today's episode is on hypothermia. And no better way to tackle this episode than with colleagues and friends, Dr. Sean Hudson and ENP Ben Cooper. So Sean Hudson has had a portfolio career in medicine. He's currently a GP in the north of England with a specialist interest in pre-hospital care. He's also a consultant for an international retrieval and reach-back company and a medical consultant for the Foreign Office. He also volunteers for Halo International as a medical director on demining operations. He's medical director for Tyrolus, a counter-poaching training and delivery company, and his passion has been providing medical cover in numerous countries and specialities in the Middle East, despite having awful Arabic. In his previous life, he was an expedition medic and has helped set up expedition medicine in its former life and developed many of their courses. He's got a particular interest in the use of manipulation of healthcare in conflict and is currently studying a PhD in the weaponization of medicine. So welcome to the podcast, Sean.
Good morning. Why do I always say good morning? Tell me it's morning where you are.
It's evening where we are, but that's absolutely fine.
Good evening.
That's absolutely fine. Ben, sorry, Sean, I should have probably mentioned your Arctic experience, Sean. So just as we proceed right now, do tell us a little bit about your Arctic experience.
I've done 4 seasons in Antarctica, most of them with Ben. I had to have a child every time I went down to Antarctica. That was the quid pro quo. And I think I've done about 10 or 16 North Pole adventures as well. So whether that's dog sledding or skiing or
10.
I've never actually been to the North Pole. I've been to the South Pole, all the poles in fact, and was lucky enough to take a very important French gentleman around Antarctica a few years ago and got to visit most of the polar stations as well, which is fantastic.
Fantastic. Ben, welcome to the podcast.
Morning.
Morning, Ben.
Morning, Ben.
Morning, Sean.
Ben has worked as an A&E department in the A&E department in Sheffield for over 20 years and is an A&E department charge nurse and an emergency nurse practitioner. Since 2004, his pre-hospital career has taken him to the south of Antarctica with ALE, Antarctic Logistics and Expeditions. He spent time at ALE's field camp at Patriots Hill and then on to Union Glacier. Ben did 6 seasons with ALE on Union Glacier, which is home to some of the world's most remote field hospitals. He's also helped there provide medical cover and rescue to all the expeditions skiing to the South Pole, climbing Mount Vinson, Antarctic marathons and ultra races, alongside escorting clients on flights to and from the South Pole. Ben is also a member of the WEM teaching faculty since 2008, and he's also taught and directed on many of the UK courses and European courses, and specialises in the polar medicine course in Arctic Norway since 2009. So Sean, my first question to you, so this is a podcast on hypothermia, and so no better way to start the podcast by really just defining hypothermia and just getting from your perspective, what the best way to perceive the condition is.
So if we try and keep it really simple, hypothermia is a byproduct of the fact that heat loss is greater than the amount of heat that you can gain. So keep it simple. And I think we probably all understand that you're going to lose and gain heat by sort of 4 modalities, aren't you? You've got convection, conduction, radiation, and evaporation. It is really quite confusing when you read the literature, because they're very defined in terms of the temperatures that you will find somebody with a type 1/B hypothermia. But when you're in the field, it is almost impossible to measure somebody's core temperature. Absolutely. So Gordon Giesbrecht, who Prof Popsicle, did a study of which n equals 1, and he looked at right atrial temperature, esophageal temperature, and rectal temperature all at the same time. He plotted out a fantastic curve. They all eventually come to the same point, but esophageal and atrial are pretty specific to and represent the temperature that you're at the time. But rectal temperature can lag sometimes up to an hour, because of course that thermometer, even if it's a specific low reading thermometer, could go into a piece of feces, and the temperature is going to be not your core temperature. So if we keep it really simple again, if we go to Gordon Giesbrecht, and he's defined it as in 3 sections. So our normal core temperature, 36 to 37. Interestingly, it's actually decreased over the last decade, but we're looking at core temperature 36.5. You become hypothermic, mildly hypothermic, when it's 35. You become moderately hypothermic at approximately 32. You become severely hypothermic at approximately 28. And so for us in that pre-hospital sphere, what we are less interested in is exactly what somebody's core temperature is, because we'll all vary at the point at which we will develop the signs and symptoms that would represent those core temperatures. But initially, effectively, you will start shivering, and shivering starts at a really early phase. You recognize the fact that it's cold, your peripheral thermoreceptors go, wow, it's a bit chilly here. I'm going to need to generate some energy as the byproduct of shivering before I get cold. So if somebody's shivering in that initial phase, they may well not be hypothermic. Shivering then moves through this phase of going into becoming more convulsive, and it'll wax and wane, and then eventually shivering will stop, and that's going through mild, moderate, and severe. If somebody is mildly hypothermic, so if you're in that 35 to 32 bracket, you can, and they're shivering, you can define whether they're mildly or moderately hypothermic by just getting them to stop. If shivering's under voluntary control, they're mildly hypothermic. If they can't stop the shivering, they're probably moderately hypothermic. And then, of course, your cognitive function will decrease as you move down the temperatures. I like that moderate hypothermia presents with the stumbles, fumbles, mumbles, and grumbles. So people they're ataxic, they're dysarthric, they change their behavior, and they'll often take clothes off, they'll whinge and moan, they might sit down and not wish to do anything. So that change in behavior and the ataxia and the dysarthria is quite a good indication of moderate hypothermia. And then, of course, when somebody's severely hypothermic, they're rigid, they're pale, they're often pulseless because they may be quite profoundly bradycardic, or they may have AF, or a terminal event, they might have VF. So that, in a sort of very quick run through, is an overview of sort of Gordon's classification. We use tympanometers a lot in the UK to define define somebody's temperature, but you've got to be aware of what you're trying to do is you're firing that infrared beam onto the tympanic membrane. So if something's in the way, you're not going to get a true reading of a core temperature. So I would urge people to do rectal temperatures if they really want to get an idea of what somebody's core temperature is.
Yeah, indeed. Sean, thanks for that. That's really comprehensive. So my next question to Ben would be, from your experience, Ben, what makes it someone more sort of preferential to hypothermia or exposed to hypothermia from both internal and or external factors?
So sort of the predisposing factors from hypothermia from an internal, let's start with internal, are reduced heat loss. And this can come in with extremes of age, hypothyroidism, hyperpituitary gland problems, hyperglycemia, starvation, and also with race and gender. And then we can get an increased loss through skin disorders, severe burns, and alcohol and smoking. And then we can get an impairment that we can't feel the cold. And this often is caused by alcohol, CNS injuries, medication prescribed or not, such as benzos, and beta blockers, or trauma. Now, from my background of sort of UK mountain rescue, we often get called on a major city on the edge of a national park. We often get called out to suicides and overdoses, and of those, we can get a medication list. Benzos will be amongst them, and that can obviously reduce your ability to feel the cold. And also, as one of the busiest mountain rescue teams in the country, we see a lot of trauma. And again, person lying on the floor for a significant amount of time, either scared to move or being told by a 999 service not to move. And obviously they'll lose heat through conduction to that floor. Then we've got external factors, weather, wind, rain, temperature, snow. And obviously we've got the wind chill factor, which is sort of wind and rain, or wind and temperature on exposed skin. So let's just say 5 degrees plus a 15-mile-an-hour wind on exposed skin, you're looking at around about, it feel like -13. So again, from my mountain rescue background, I'm going to look at a few of the things. So this chap called Griffith Pugh was a medical officer tasked to investigate the 1964 4-inch challenge, where 3 men died and 4 had a near close call with hypothermic death. And the study of this looked at the effects of the wet, windy conditions on clothing worn, and only 1/10 of the original insulation value was remained in the clothing of the individuals found. And again, this goes back to sort of my mountain rescue and call outs and what people are carrying. And obviously this chap Pugh was the medical officer in the Second World War. He went on the Everest 1953 expedition. He went to Antarctica, and he also was one of the first medics to look at cross-channel swimming. He's got an amazing obituary in the Independent. And in his conclusions, wet, windy environment was key to death. Poor thermal insulation of clothing, walking to the point of exhaustion or exhaustion hypothermia, thin and low to no body fat. And also one of the individuals that died had a recent illness of flu 3 weeks prior to the event. And obviously they went on to recommendations, and they were all very, very basic recommendations. And if you look at today's events, adventure races, and advice for people going out into the mountains and in an environment that was suitable clothing for that environment, spare and dry clothes, waterproof jacket and trousers, and an emergency shelter, which I find quite interesting in the fact that when I first joined mountain rescue up in Northumberland in
1893,
the Kissus were around. And I'd never seen one of these before, and it was called a Carrymore International Survival Shelter Unit, I think. And only in the last maybe 15 years have these become available on the market for people to use and carry. And they're very cheap. They're very light, and they're a very quick tent to put up. And then obviously commencing rewarming. And onto that list in today's world, I would add on a whistle and torch and food.
That's comprehensive, Ben. Thanks for that. I think that's absolutely relevant, and like you said, those predisposing factors can certainly play into the pathology. So that's really interesting. So Owen, Sean, just
Owen,
yes, mate.
There was a really interesting study in Alaska a couple of years ago that looks at the principal external factors for hypothermia, and it's a bit like the list of things that will cause an Australian to be eaten by a crocodile. And so it was alcohol, drugs, psychiatric illness, and vehicle breakdown. So they're the sort of, which is interesting, because we imagine that people are out skiing and climbing, but actually the majority of people who get caught out in these really cold environments is simply because their vehicle breaks down, or they have another intercurrent illness, or they're drunk.
So that's really interesting, actually.
Sorry, going on to that, a couple of weeks ago on Twitter, there was an excellent article was going around, and it was by someone called testedtodestruction.blogspot.com, and it was called "Go Outside, Sit Down, and Wait." And it was aimed at sort of mountain bikers and adventure runners who then get an injury and have to then call mountain rescue. And obviously these people can move really fast, but then by the time they stop, they get sweaty, they get cold, and then they call for help, but it takes sometimes an hour to 2 hours to 3 hours for help to get there. And it looked at, and it was advising on people to carry more clothing and more equipment in these more adventurous races. Sorry. But yeah, testedtodestruction.com. Go outside, sit down and wait. Fantastic article.
That's great. We'll provide that in the show notes, actually, Ben, because that sounds really interesting, actually. So we're on expedition, or we're just about to go on expedition, Sean, to the South Pole. And there's a whole number of patients that you're going to take out. What are some of the red flags from the medical predisposing factors that you would want to pay attention to and or pick out?
I think probably the principal diseases are going to be neuropathies and endocrine diseases. So any sort of endocrine dysfunction is going to predispose you to hypothermia. It doesn't mean that it's insurmountable. It just means that your hypothyroidism or your diabetes just needs to be under really good control. You need to understand how you're going to deliver care for that chronic disease and the environment that you're going to. Neuropathies are quite a challenge because the person often doesn't have a perception of how bad the cold is, because they sometimes can't feel their extremities. But again, I've taken a lady with quite a profound neuropathy on a polar dog sledding trip. She was at high risk of cold injuries and probably of hypothermia as well. But it is understanding the limitations placed on the person by the disease that they got, and then how you manage that. I think probably, none of these should be stops for any sort of expedition, but I do get concerned with psychiatric illnesses, especially affective disorders, because lithium is a medication that can predispose to hypothermia as well. And then, I always want to make sure that anybody who's a previous history of mental health disorders is stable before they come away, because they're challenging environments to go to at the best of times. Again, it doesn't mean they can't come. We just need to be aware of the impact that disease is going to have and the environment is going to have on the disease. So they're pretty much the sort of things that I would predominantly look for. And we would go through everyone's medical history, and they need to fill that in. And it needs to be signed by their medical profession, whoever normally looks after them. But it's rare for us to stop people coming to Antarctica. We've had some people with really quite profound diseases, because it's often a tick box. The end of a life, people want to get there to see the South Pole, and it's hypoxic and it's cold and the altitude is high and the pressures are low, and they don't realize just quite how hypoxic they're going to be when you get to South Pole. So that is probably more of a challenge to us, interestingly, at South Pole than the cold is. I can keep somebody warm, but we often have to deliver oxygen to individuals with chronic diseases, when we're taking them down, because the South Pole is 2,500 meters, I think, isn't it, Ben?
Yeah, 10,000 feet. Yeah, and it also depends on air pressure at the same time. Because
of course, we're moving into altitude medicine now, but of course, if you've got a really cold column of air, you get a high concentration of oxygen right at the bottom, of air at the bottom, and it's less as you go. So you're 2,500 meters. Partial pressure of oxygen is actually lower than you'd anticipate because of the cold. And then if you get a massive low barometric pressure coming over the top of it, that reduces it even further. So I've flown into Concordia, which is the French-Italian base, which is only at about 2.5 to nearly 3,000. But the meteorologist said on the day we flew in, it was about equivalent to nearly 5,000 meters. My saturation dropped to 65. And the chap I was looking after, his saturations dropped to low 40s, which was a challenge because he had quite a lot of heart disease and liked to smoke a lot of cigarettes. Even when he was having nasal oxygen, which did concern us a little bit. as he blew up the base. He didn't.
Did you see Alex Kumar while you were there?
I did, yeah. I think what we haven't spoken about, I don't know if you're going to, we haven't spoken about this sort of behavioral and autonomic responses to hypothermia. Were you going to cover that?
We did touch on that actually. I think
within
sort of cold exposure.
Okay.
Yeah. So we're
on it.
After that shortly. And Ben, and then Sean. So my question first to Ben. So this is just for headlines, take homes really for people listening to this and or watching this on the WEM Academy. What have you learned from personal experience around self-care in avoiding hypothermia over sort of multiple trips and multiple years really in these environments?
I remember my first polar medicine course, having been to Antarctica about 4 times by then, 3-4 times by then. And Kerry Williams was in charge of the course. And Kerry was an ex-PTI, colour sergeant with 4-5 Commando. And he was course director. And his opening line was, "Be bothered." And I thought, and it still stuck to me today, and I think that's the same for all environments, extreme environments that you're in, be bothered. And so at the end of the day, when you're tired and want to eat, it's about being bothered to dry your kit out. Hang your kit up to dry, take your linings out of your gloves, put them over something warm or hang up in your tent. Take the lining out of your boots, hang them up in your tent or put them over something warm. Hang kit up that's been wet in that day so it's all dry for the following day. And that's always stuck with me, that phrase, be bothered. I like the mnemonic COLD, which stands for obviously clean, open, layers, dry. So clean clothes are warm clothes. Be a bit able to open your clothes up and vent so you don't overheat. Because as we all know from our Norwegian friend, if you sweat, you die. And layers, lots of thin layers are better than thick 1 or 2 thick layers. And dry clothes are...
Weren't you part of that competition that we had in Antarctica to how long you could keep a pair of underpants on without taking them off?
Who was that?
I think I got to 62 days.
Did you?
You weren't allowed to take them off your legs. I nearly killed everyone in the airplane when we got on in Punta Arenas.
Oh, that was it, because you came off the ice and went straight onto the land Chile flight, didn't you?
Yeah.
With your full thermals on.
I thought everyone was going to die.
You'd been a CBRN incident yourself.
Peeling them off your legs.
You stole my line there.
And then obviously D, dry clothes or warm clothes. And obviously the correct clothes for that environment. You see it all the time in the UK. At the end of this week, we're going to have a cold front come through and it's going to be raining and sleeting. And people will put on a big down jacket to keep warm. But the down jacket will absorb the water, it'll absorb the moisture, and it loses its thermal properties. So down's great for minus temperatures at cold latitudes and altitudes. But actually, for a UK environment, it's not good kit. And I would say invest, as my mate James Thacker says, who's a mountain guide, invest in your fingers and toes. So if you're going to spend money, spend it on gloves and socks and boots, and not as much on it. And he says he sees a lot of people will spend a lot of money on a big jacket, but save money on gloves. And with gloves, I've always been a big fan, having seen a lot of frostbite in Antarctica, of having idiot loops on all gloves. It's the first thing you see in the European ski fields, really, as you get on a ski lift in the first 30 meters, you'll always see a single glove on the floor. Someone's got on the ski lift, they've got the phone out to take a picture, a selfie, answer a call, and they'll drop a glove. And that's a very quick way of getting frost nip when you're moving at speed. And a few good books, like Sean was doing before, a few good books. Obviously, Christmas is coming. So Keeping Dry and Staying Warm is a new book that's come out. And as well as discussing with Sean yesterday, it's called The Secrets of Warmth. So they're my top tips.
That's fantastic. Absolutely fantastic, Ben. Some really good take-homes there, actually. Sean, over to you. Some of your take-homes that you've just kind of learned or been reminded of over the years.
Well, my kids are sick of hearing the mantra, be bothered. But I'd agree. Kerry Williams and Eddie Cole, it came out of their mouths, and it's all about, any expedition, especially in a cold environment, requires people to all pull together and deliver. And probably one that I don't adhere to, because I'm a bit of a grumpy old sod, is only say positive things. Because if you whinge and there's two of you and it's remote and it's miserable, it will just get you all down. So that's the sort of the psychology. I think the 6 P's of preparation. You've got to run through it all. You've got to run through how you're going to do everything because it's so cold. You cannot, as Ben said, you cannot drop your gloves. I dropped my gloves on one of the first trips I did to Norway with a camera crew because somebody was really sick. Actually, they fitted in the middle of the night off the back of a dog sled and we had to dig a snow hole. I didn't have idiot loops on my gloves and got frostbite in the ends of my fingers. And now if I go to a polar environment, they're looped around and behind my body always. Layering, buy the best stuff you can get a hold of, whether that's the Norwegian Ulfrot or whether it's Basque. The Russians make some great stuff. But just get your layering right and never have skin onto a cold surface, because if it's really cold in Antarctica, it'll just freeze. It'll be like a cold burn. Calorie intake, hydration, of course, really important. You can't generate heat if you haven't got enough calories in, and you will burn through the calories really quickly. A really common injury that we see is skier's thumb. And it only seems to happen, I think it only really happens in British expeditioners going to the South Pole, because they don't really, a lot of them haven't done a lot of preparation in skiing before they come away. And they grip those poles like outriggers on a boat. And of course, the grip that they have means that they reduce the blood flow to the thumbs. And it's just all those little things. So making sure that your gloves aren't too tight, that your ski poles are the right size, that when you've got your massive mitts on, you can actually get them around your ski poles. So it's the minutiae that makes the difference in these environments. And as Ben always says, don't sweat, because if you sweat, you'll die.
I think going back to Sean's thing there, but I think with the skier's thumb, a lot of clothing these days has a thumb loop on them. It's where you push your thumb through the clothing, and that in itself, if it's too tight, can automatically start cutting off circulation to your thumb. So if that is the case, then it'd be better off to remove that thumb loop. And also, if your kit doesn't keep you dry in the UK, doesn't keep you dry and warm in the UK, and the kit doesn't work in your back garden, and you then don't be taking it on an expedition. So I think for me, if the kit works in the Peak District, it's great. If it works in Scotland, great. Then it goes on a trip. But if it's not keeping me warm and dry in the peaks, then I'm not taking it anywhere else that I'm going to have to rely on it.
Just going back to your value of spending money on your fingers and toes, I remember I bought some heat pads for the inserts for my 8,000 meter boots. I remember whinging to Chris Emery about how expensive they were, and he went, "Mate, that's £12 a toe." It's worth every penny that you spend on those heat pads. And he was absolutely right. They were invaluable.
I think when it comes down to it, like you said, attention to detail is absolutely key. And you're right. If it's not tried and tested and proof of concept hasn't occurred elsewhere, trialing out boots or gloves for the first time, and or jackets for the first time in extreme environments, any extreme environment, I think, is never a good idea.
Yeah, no, recipe for disaster. Scotland, however, is an excellent stomping ground to, if you can get along in a cold, wet Scottish winter, the chances are you'll be absolutely fine in northern Norway or in Antarctica,
Yeah, it's
because
good.
it just tends to be drier. It's pretty cold, but it's miserable when it's cold and wet in Scotland. Some of the most miserable times I've ever had.
I think in one of Chris Imre's things is a new trip, new socks. New trip, new socks.
Yeah.
There's a lot of time you wear your walking socks. You've paid 20 quid for a pair of walking socks. You wear them and you actually knock the insulation out of them. And then if you're on big mountains, there's no insulation properties in your socks. A lot of people have spent a lot of money, we're talking sort of $50,000 plus on these big mountains, to spend an extra £100 on some brand new socks to keep your toes nice and warm is money well spent in a vascular surgeon's eyes.
Yes. Oh, and are we going to cover treatment of hypothermia?
Yes, absolutely. So we're just about to come on to that, actually.
Okay,
my next question, actually, no, that's fine. My next question, actually, Sean, is directed to you, and is around the innate autonomic response to sort of cold water immersion, and how we can understand it from a physiological perspective, and or maybe tackle it. So if you could just run us through the autonomic response and what happens on a sort of on a physiological level.
Yeah, I tell you what, should we run through hypothermia autonomic, or the response, and then we can look at the differences that you get in the cold water, because it's just ever so slightly, it's nuanced, but it is different. So the first thing you'll do when you get exposed to the cold is you'll have behavioral changes. So you'll recognize that it's cold. You think, wow, space is pretty chilly. What I need to do is get a shelter up, or I need to get out of this cold environment, or I need to get some warm clothes on, or I need to have a hot drink. But what's going on so with your autonomics is obviously you've got a vasoconstriction. You're shutting down the blood flow to the peripheries, because you want to bring all that lovely warm blood and keep it going through your principal organs. There's an interesting response if you only expose small parts or individual parts of your body to the cold. So say your hands, then you get what's called a hunting response. So you put your hands in cold water, they vasoconstrict. Your body recognizes that by vasoconstricting, you'll predispose it to cold injury. So it then vasodilates and vasoconstricts. And when we come to talk about frostbite, you'll see people exposed to the same challenge. Jamie Andrews is probably the best example. You'll see people who shut down and don't have that. You imagine that they don't have quite a profound hunting response, but they don't get as hypothermic, whereas individuals that they're with will have it. They lose heat and they become more profoundly hypothermic. So anyway, so you get your vasoconstriction, that might cycle, but then eventually that turns off and you vasoconstrict constantly. You get shivering, because obviously you're trying to generate heat. You can increase heat production with shivering thermogenesis easily 5 times, and even more when it's quite profound. You'll get a diuresis, because of course you're not supplying blood to the biggest organ in the body, to your skin. So your renal function says, well, volume's increased, I need to peel this out, which is interesting when we come to talk about cold immersion, because that can result in a collapse. And then in that initial phase, your heart rate will go up. Blood pressure may go up. It normally remains about the same. But as you move down the temperatures and you start to go to moderate and severe hypothermia, your heart rate will slow. You become bradycardic. You're then liable to develop arrhythmias. You might get AF and VF. You get decreased platelet function. And you might get changes in your clotting cascade, because enzymatic actions will change as well. And you get a similar presentation to sort of DIC. That will be your end point.
Yeah.
Treatment of hypothermia is really simple. It is just about getting out of that. Sorry, are you going to cover treatment later?
We're going to cover treatment shortly for frostbite and for frostbite, but treatment actually, because they're both nuanced, quite rightly, as you said earlier, Sean. So we can move into treatment of sort of more generic.
We can do that later, mate. I can talk about cold water immersion. You'll run through exactly the same plethora of autonomic responses, but really interestingly, you've got 3 phases. Well, it depends on whether you're wearing some sort of flotation device. It may only be 2 in your response to cold immersion, obviously, rather than submersion. So when you get into the water, you've got that gasp response that you don't always see, but most people will elicit it, where you just hyperventilate, and it's hard to control that. And that hyperventilation can result in aspiration. So again, Prof. Popsicle, Gordon Griesbeck, has done a really nice little public service announcement in the same way that Sammy used to tell us how to cross the road when you were a kid. Gordon Griesbeck tells you what to do when you live in Canada and you fall in the ice and you need to get out. So it's all about getting your breathing under control. Once you've done that, things are calm. You've then got a window of opportunity before you'll get a fine and gross motor dysfunction. The time for that to come on really depends on how cold the water is and your morphology as well. Ben and I were discussing this yesterday, and I'm trying to discuss this with Heather Massey who's at the Institute of Naval Medicine at the moment, about whether you can acclimatize to cold and whether your body gets used to the cold, and hence your gross motor function and fine motor function can be maintained for longer. Yeah, just from a personal experience, I'm not convinced whether it changes that much, to be honest. I think a lot is driven by your morphology and your level, your reservoir, your level of your exercise capability and capacity, how cold the water is, etc. But so you've got the gas response, you then have loss of fine and gross motor function, and then you'll get hypothermia. In order to get hypothermia, you've got to have a buoyancy device on. It takes a while, and you're going to drown because you can't swim before you become hypothermic.
Yeah, indeed. So that gross motor loss of gross motor function. Yeah.
I was looking the other day. I was just for this conversation at what is cold water, and I found this outdoorswimmer.com, and basically they say cold water is water described anything less than 15 degrees, and on the outdoorswimmer.com, so water between 10 and 15 degrees is described. Their technical term is nippy. Between 5 and 10 degrees is effing cold, and between 0 and 5 degrees, the technical term is bloody freezing. And then obviously that's on this paper here, but it's just saying that 15 to 20 degrees is the English Channel in the summer.
That's balmy. That's my shower at the moment.
Balmy is 20 to 25 degrees, and stifling is 25 to 30, and hot is more than 30 degrees. But cold water in the UK is described as anything below 30 degrees. Sorry, 30 degrees, 15 degrees.
15 degrees, okay.
15 degrees, yeah.
And so and going on to this 1-10-1 is the sort of the new phrase that people use, where you've got 1 minute to gain your control of your breathing. And if you've got warning that you're going into the cold water, to try and go in slowly and keep your head above the water as much as possible. And then once you're in the water, the R and the I are now talking about the mnemonic float, which means fight against your instincts to panic or swim hard, to lean back into the water, keeping your airway open. Open your body up like in a star shape, so you float. And gentle actions with your hands and feet will keep you afloat, and time. So this is up to 60 to 90 seconds to control your breathing, and then you've got 10 minutes of meaningful movements to do a self-rescue or put a life jacket on, or get hold of something to help you float, or get out of the frozen lake. And I remember on the polar medicine courses, and people, probably Sean would have been saying actually, or it might have been Matt Edwards, because he's got a beard, that if you get your hands above the ice and put your jacket will automatically freeze to the ice, and that'll stop you from going under. And if you've got a big beard, to rest your chin on the ice, and your hair of your beard will stick to the ice, and you'll stop you from going under and drowning. So
you could get your quiff, Owen, just to put. Oh, Ben and I, we absolutely stuffed. Yeah, my only chance would be to get my nasal hairs onto the ice,
or a licking,
or the ear hair.
Yeah.
I get my hair gel on there, and there'll be no.
Oh, mate, that's not coming off.
Yeah,
you have to get the fire brigade when they eventually come round to get that off.
And so your beard then sticks to the ice, and it stops you from going under, and therefore you're found on the surface rather than being found often in the spring or when the ice breaks. And then you've got 1 hour before becoming hypothermic and losing consciousness. That's 1:10:1. And I was looking at some drowning stats really, and drowning is the third leading cause of death in the world, and it works out at 42 people per hour die of drowning. 550 UK deaths, mainly in the summer months and mostly on inland waters. And also, I'm looking at holidays. Sadly, a lot of children die on the first and the last day of holidays. And they put that down to arriving at a hotel complex. The kids get in the pool, they're not being supervised, or mum and dad say go to the pool and we'll come down in a minute, we'll sort the suitcases out. And on the last day, packing up, and the kids are getting overconfident of their ability to swim, and they're not being supervised. I found that quite a sad statistic, really.
I think what we didn't mention earlier was going back to cold water immersion is obviously cold water will conduct heat away 25 times quicker than air, so you will become hypothermic much quicker. And also we didn't mention that hydrostatic effect as well, so that pressure on the skin, although it's not perceptible, increases the diuresis, so you'll decrease your plasma volume, which can then result in this collapse, when you're post-immersion collapse, so when you're rescued. And Ben and I were discussing yesterday, the Fastnet, when the race was on and guys were getting rescued, they'd been in the water for pretty prolonged periods of time. They were alive when they were being picked up, they were dead, or they had collapsed and were unresponsive when they got into the helicopter. And that's because they were being lifted vertically, lose the hydrostatic pressure, massive diuresis, that in conjunction with hypothermia. So there was a move to horizontal rescue. And like anyone who's hypothermic, if you are rough with them, they are very unstable cardiac tissue, and they're very likely to have an arrhythmia. And VF is very common. So if you handle somebody really roughly in the context of managing hypothermia, the likelihood is you probably put them into VF. Yeah. So they say treat them like porcelain, don't they?
Yeah.
That's
right. I'm mindful of time, chaps. So I'm just going to move the conversation on slightly because of time. So I'm just going to ask Ben to differentiate between frost nip and frostbite. Then I'm going to come back to you, Sean, and talk about the management of frost nip and frostbite, because like you said before, it's quite nuanced. And so, Ben, could you just define frost nip and frostbite for us?
So frost nip is a reversible freezing cold injury, which will resolve completely within 10 minutes of starting to rewarm. And it will, appearance, skin will peel pale, and it look like candle wax, a drop of candle wax on the skin. It's really common in cheeks, chins, and earlobes that are exposed to cold, and more so if they're exposed and you're traveling at speed, so running or skiing or skidooing, or naturally the wind increases because of bad weather. I think I got nipped once in Arctic Finland. It was about minus 25 in the valley. It was about 20 to 25 mile an hour wind. So the wind chill factor on bare exposed skin was about minus 55, minus 58. So frostbite within 10 minutes. And I was trying to get my camera out of my bag, take some pictures, and I had big mitts on. And I had to take my mitt off to get my camera out and take some pictures. And I remember my index finger getting really cold very quickly. And then so simple treatment measures of frost nip, simply by pulling the hood down, putting a hood up, or pulling a hat down, wearing a ski mask or balaclava, or goggles, simply covering that exposed skin, seeking shelter, or putting a warmed, ungloved hand over that area should sort out the frost nip. Now, if it doesn't, then that's when you've got frostbite. So frost nip should be able to be fielded, sort of fixed in the field. You should never see it in a hospital and sort of type of setting. But if frost nip hasn't sorted itself out within the field with simple measures, then you've got frostbite.
That's comprehensive, Ben. Yeah, that's comprehensive. So Sean, just talk us through frostbite, both from a management perspective and just how you might manage them acutely and maybe over time.
So same triggers. So it's cold. It's interesting talking about wind chill. Obviously, wind chill only has an impact on areas of skin that are exposed. If your clothing's all done up, wind chill, it doesn't really have an impact. So it's got to be cold, got to be exposed, restricted clothing, hypothermia, increased pressure. So ski boots. We often see kite skiers these days in Antarctica. They'll be on a reach for sometimes a whole day, and hence the pressure is only on one side of their feet, and they'll get cold injury as a result of the pressure and the cold. Previous frostbite, of course, means you're more likely to get it if you go back again. And then there's certain medication as well. Anything that is a vasoconstrictor, so beta blockers are probably the most common thing. But the pathophysiology of frostbite is you get ice crystal formation, extracellular predominantly, but intracellular as well. And then probably the principal pathophysiological cause is you get vascular occlusion. So you get platelet aggregation, you get endothelial damage. In one respect, it's really similar to what we're seeing with COVID at the moment and the multi-embolic effect as a result of endothelial tearing. And the platelet aggregation is probably driven by thromboxane A2 and prostaglandin, which then becomes that, why is that interesting? Because it drives the medication that we might use when we come around to treating frostbite. So it'll present, as Ben has said, you get that pale, sometimes hard, paresthetic skin. You tap it and it feels like a little piece of wood, but you can also get blister formation. So what we're looking at is the cold injury moving down through the layers, epidermis, dermis, down through and into muscle, and then of course into bone as well, so that you get cold injuries all the way through that. If you get deeper cold injuries, you'll get blister formation, and you'll see the blisters change as they go from pale to dusky, and then because they're blood filled as you go through and into the dermis. A bad sign is peripheral blisters with distal duskiness. So if you've got a purple looking digit with blisters proximal to it, that's not a good sign. A clear blister at the end of a finger with a little bit of hardness around the rest of the finger, that's superficial frostbite. But when you start to see the involvement of vascular tissue, so through and into the dermis, that's when you start to move into, you describe it as deep frostbite.
Sean, that's fantastic. So just looking at that and sort of and around the management of frostbite, Ben mentioned about the management of frost nip and the reversible causes. So you've got someone who's just presented. They've got those characteristics. They've got some deep discoloration, some proximal blisters. What's your sort of acute management in that phase?
So if they've got superficial frostbite, the first thing to do would be to change the environment. So get their limb, get them out of the environment that they're in, and try and rewarm the part of the body that's cold. And if it, as Ben was pointing out, if it rewarms and he gets normal sensation back and the tissue feels soft, you've got to change something, otherwise they'll get that again. So is the glove too tight? Is the glove wet? Are the shoes too tight? Have they left a zip open? Is it exposed to the wind? You need to change something about, and it might be that they're just a bit hypothermic and they don't have enough energy, they don't have enough calories. So hypothermia, of course, will cause peripheral vasoconstriction. So change something. If they've got frost nip, you change it, they go back, and you just keep an eye on it. If you rewarm it and it doesn't rewarm, and they're still parasitic and it's still hard, you need to seek shelter and try and rewarm that tissue properly. It's very interesting. Once you start to get, when it's superficial, you can rewarm in that environment because you don't get that post-rewarming swelling. But if you've got blisters, if you've got deep frostbite, what you don't want to be doing is rewarming in an environment that you can't keep warm. Because the worst thing you can do to frozen tissue is to thaw it and then freeze it. That line of demarcation will be your amputation point. So freeze thaw is probably the worst thing. Rubbing it, putting it in front of dry heat, and then freezing, thawing, and freezing. That will result in you losing tissue. So you've got a decision to make at the point at which you see somebody with deep frostbite. Can I rewarm the tissue here where I am without freezing it again? Or do we need to go somewhere else? And you're better walking on frozen tissue or climbing on frozen tissue to a place where you can rewarm it properly. We've dealt with people in Antarctica who've had really quite profound frostbite, and almost to a man, that tissue will swell. And the digits, the hand become unusable, and you can't fit feet back in the boots. So you take what's a manageable situation into something that is going to turn into a right drama, because you've now got swollen tissue that they can't get a boot on, and you're going to have to evacuate them from where you are carrying them. So you've got that. You're really interested in that initial decision, and it's taken a while for the frostbite to come on. It's not like trauma. You're not going through your March principles. It is, let's have a think about this and maybe a cup of tea, and we'll decide what we're going to do and where we're going to go before we start to get really excited.
Basically, right, it's that pragmatic decision making. Absolutely.
So what I would do, though, at that early stage, before I give them to Ben to work his magic with his dressings and his rewarming, is I would give them, this is coming back to the modulators, the thromboxane A2 and the prostaglandin, I always give them aspirin and ibuprofen at that very early stage. So I give them 75 milligrams of aspirin as long as they're able to take it, and 800 milligrams of ibuprofen. So that should act, to reduce the inflammation and to reduce the platelet aggregation at that early stage. And then I hand them over to Nurse Gladys Emmanuel, who will work his wonders with his box of witchery tricks.
So that point of view, we're now into an environment that person's going to then stay in. They're not going to continue to climb. They're not going to continue to ski. And they're now back at, say, for example, Union Glacier. It's a controlled environment. We've got all the resources there. That person we're going to treat for hypothermia for one, and also any other trauma. And then we're going to, if can, give them oxygen if needed. We're going to hydrate them and feed them. And then we're going to put their limb or their frostbitten area bear in mind, frostbite can attack any part of the body. It's not just fingers and toes, but fingers and toes are the most common areas, and we're going to submerge those body parts in some water, a warm water that's been pre-warmed at around about 35 to 40 degrees. So it's like a child's bath, really. And we're going to leave it in there for around about sort of 30 minutes. What we aren't going to do is have a stove underneath that pan of warm water to boil it through. It is separate warm water. And then we take the limb out, and then we're just going to let it air dry. We're not going to rub it with a towel because we're going to potentially cause damage. Let it air dry, and then cover the area in aloe vera, which is an antiprostaglandin, and then a sort of tulle-based dressing, a non-adherent dressing, and then wrap in some sort of felt that we use for putting on plaster of Paris. Wrap them in felt and then bandage that frozen area up. And again, hydrate and encourage eating. Possibly before all this, depending on the severity of the frostbite, you may want to give some intravenous analgesia, depending, because it is going to be painful when that sort of rewarming sort of starts off. And then once we've done all that, we're going to say continue to keep that person in a enclosed environment where we can control the temperature, and obviously then start seeking expert advice from that person's country. And for us in the UK, our leading expert, and is one of the world's leading expert, is Professor Chris Imray, who's a very good friend of the Wem family, and hand him over to someone like that for further continuing care.
The question I often get asked is, when do you know that the tissue is rewarmed? And as Ben was pointing out there, it's when it becomes painful. As it reperfuses, the pain's is pretty intense. I've had to give opiates to people in the past because of that rewarming. The other question I often get asked is, so what medication do you continue to give them in that transfer phase? So I just give them ibuprofen. I think it's 400 milligrams twice daily, but just a standard TDS 3 times daily dose of ibuprofen. As again, just to reinforce what Ben was saying there, that it's so important that you don't reduce the blood flow to that tissue, which means, you know, they should never go into the cold. So, you know, even that transfer from taxi to the airport has got to be as short as possible. They should never carry a bag over that shoulder. You know, if it's a hand that's got the cold injury. A little bit of champagne is very good because apparently it causes peripheral vasodilation and the bubbles are really nice. Vigilant for infection. So some would advise that if you see dermal blisters, start to give Pen-V at that stage. Others would say only start to give antibiotics when you've got an indication that there's infection there. But infection is your enemy with cold injuries. And then there's this discussion about, should I pop a blister or not pop a blister? I think most blisters, unless you're absolutely adherent to treating these things really gently, they're going to burst. So, you know, if you think it's going to burst, you're probably better to remove the fluid, and then it's under a bit more control and it's a bit more aseptic. They're going to need a tetanus if they're not tetanus covered already. And I think more than anything, you got to be patient. Do not let anyone chop off a digit because it looks black and eschar, and because it is survivable. It's incredible how tissue will reperfuse and you'll get normal function back again.
There's an old-fashioned saying, isn't there? It might be an Inuit one about frostbite in January, amputate in July. And it's about leaving the body to do what the body needs to do, unless the person becomes septic, like the Jamie Andrews, where he got frostbite. Sadly, his friend Jamie Fisher died. And Jamie Andrews got frostbitten hands, both hands and both feet, and then went into sepsis, and then lost both hands and feet with below elbow and below knee amputations. And this classic, obviously, Ranulph Fiennes out there who got bored. His finger became irritable and put his finger in a vice, and snapped off, or got a junior hacksaw and cut through the bone to cut through the frostbitten area to get rid of that bone. He became impatient.
I think it was a Black and Decker saw he took it off with.
But you want there's a few horror stories out there by people who have seen experts and had fingers removed or toes removed and a thumb removed and then a big toe removed and sewn back to where the thumb was, and then the body's then rejected the transplant, and that person's then lost the ability to walk, and also lost the thumb. So there is one or two sort of horror stories out there where people have seen an expert who isn't an expert, and I would always seek Professor Chris Imre's advice straight away. And in some parts of the world, frostbite equals amputation, and that's depends where you are, has its problems. And again, time, unless infection is dictating, time is your friend.
There are some tests you can do that will tell you about tissue viability, of course. So you can do, bone scans. You can do MRIs. I think the window, the gold standard is you want to be doing that within sort of 2 to 3 days if you can. But if you need to do it outside of that, you do it when you can. It'll tell you the depth of the frostbite. It'll tell you the viability of the tissue, and it'll give you an indication of where you are likely to get reperfusion to. And there's a number of drugs that are now, so you've got alloprost infusions, you've got pentoxifylline, the French use buflamedil. They increase blood flow, and the vasodilators as well. And then there's TPA, I think, is sort of gaining credence, and it appears to reduce the amputation rate if it's given early enough. We were looking at alloprost for Antarctica, but I think the cardiac or the arrhythmias that you can get as a result of alloprost, we weren't willing to take that risk when we're so far away from advanced intervention.
So some of those scans were used by Emmanuel Cauchy, who was a French surgeon and also mountain guide, called the Cauchy score. Sadly, Emmanuel died in an avalanche 2 years ago. He was a great friend of Chris's. But yeah, the scores are called the Cauchy score.
I didn't realize that.
Yeah, fantastic, guys.
Yeah,
listen,
it was really sad actually, because I'd been up in Arctic Norway with Chris in 2018, and he was answering an email, or we were answering an email for him, and whilst we were up there, and then we got back home, and about 2 weeks later, a Manny was killed in an avalanche, and basically that pushed Chris to be the world's leading expert in frostbite, because before that it was Manuel Cauchy.
Guys, I'm mindful of time, and I think we've covered everything I set out to cover. But just to finish off, is there any pearls of wisdom or take homes you'd just like to leave the audience with, just as a resounding summary of what we've just talked about?
We didn't cover non-freezing cold injury, and it is worth people just having a little read about, because it causes a huge. So within the UK, it causes a huge amount of morbidity, and can result in changing people's enjoyment of the outdoors. So I would say, remember tricyclics, early intervention, and it is very good if it's taken early for chronic pain. I would say never give up on the hypothermic patient in the pre-hospital environment. Seen too many people who have recovered reasonable function with protracted periods of hypothermia, and that is generally in the context of avalanche and a cold water immersion. So don't give up. That there is, you know, that is the warm and dead.
Yeah, I think that's the classic Kevin Fong book, or about life in the extremes, where he goes to visit Anna Bagenholm in Norway, and it's well documented on a YouTube clip. And his book itself is a very good read. And yeah, it talks about Anna Bagenholm and her dropping her temperature to 13.7, I think, and surviving. And now she works as a radiologist in Tromsø, I believe.
She does, yeah.
Yeah. So there's, for me, there's some great books out there. There's obviously lots of clinical documentation, but for me, I get my excitement in my reading around books like Cold by Ranulph Fiennes, or when it comes to the water, Essentials of Sea Survival by Mike Tipton. It's a fantastic read. I looked at it today on Amazon to see how much it would be. I just fancied a copy myself, and the cheapest copy on Amazon at the moment was 140 quid. So I thought I'll wait till I see that in a second-hand bookshop. But also another great book is Cairngorm John. It's a fantastic book into the inside of Scottish Mountain Rescue, and in it looks about hypothermia and decision making with the young casualty, and people lying under bodies while they're having CPR to try and give off heat because the patient's so young, and the group dynamics and the thought process that go with that. But as Martin Rhodes would say, mild, moderate, severe hypothermia will kill on the hill any time of the year.
So thanks, guys. Listen, that's really comprehensive, and I think there's pearls of wisdom across the conversation. So I just want to thank you both for your time and just inferring your experience over the past hour. So thanks, chaps.
It's a pleasure.
Yeah, nice to see you guys.
And we'll catch you again soon on the next webcast academy session. Hopefully with another turkey and
I'll carve him up.
Or two. Thanks, chaps, and we'll catch you soon.
Cheers.
See you guys.
Cheers, chaps. Bye.
Legends.
Bye.
Thanks, chaps.
See you soon.
See you soon.